Thanks very much to the organisers for the opportunity to take part in this really interesting conference. I'm very much looking forward to the Q&A sessions and the contributions of all the different speakers. My purpose today is to cover the specifics of assessment of delirium in the ED. I'm going to start with a little bit of context, then I'll move on to the methods focusing on the 4ET. So Daniel Davis has already covered how important delirium is, but I thought I'd just set a little bit of context up in relation to the specific issue of delirium in the ED. So this is from one of my blogs, and these are 10 general reasons to detect delirium, all of which really apply to delirium in the ED. And I won't go through all of these in detail, but I think it's important to see that there are many different reasons why we should detect delirium. And I think it's really unarguable that we should be doing it and we should be calling it delirium. And actually, I think the only reason you need to care about delirium and to detect it and call it delirium and then manage it is the large amount of distress that's commonly present in delirium in patients who have it some of the time, if they have hallucinations or other sources of distress. But also, families are always distressed when their loved one has delirium, and that can really be made a lot worse by the lack of a diagnosis and the lack of clear communication. Another reason, of course, is the relationship between delirium and poor outcomes, including mortality. And this is from a paper that we have in press that will be out in a couple of weeks, which shows that a positive 4ET score, the 4ET is a delirium assessment tool, is associated with 5-fold 30-day mortality. And this is done at the front door, including at the ED. Recognition of delirium in the ED is important for all the reasons I've given. And I think another reason which is recognised in a few papers now is that if you don't recognise delirium and such patients are sent home, then they often have worse outcomes. These can include mortality, but also readmission. So for all of these different reasons, the Royal College of Emergency Medicine, in its report on assessing for cognitive impairment in older people, suggested that we should be doing cognitive assessment in the ED, and this should include assessment for delirium. And the 4ET, which I'll be talking about later, allows for assessment of both cognitive impairment and delirium, and it is the recommended tool. And also it's recommended that there's clear documentation of the cognitive impairment, including the delirium. However, we know from that audit, and actually many audits around the world, that unfortunately the ED is still struggling to detect delirium at any kind of consistent level. And probably even in the UK, where we're getting much better at inpatient delirium detection, it's still quite poor, unfortunately. And probably the main reason is that we don't have standard processes for screening for delirium in the ED. That is, we don't use tools. And this creates lots of problems, including the risky situation of people with undiagnosed delirium in the ED being discharged with those poor outcomes. So now I'd like to move on to a discussion around how we can move forward to detecting delirium in the ED. First thing to say is that delirium is quite a heterogeneous condition. Although the DSM-5 criteria, which were discussed earlier, focus on acute onset and altered arousal / inattention as the main presenting features as a diagnostic criteria, in fact, people with delirium can, in reality, present with many different changes in mental status, some of which are shown there. A common presentation is, of course, drowsiness, but people often have paranoia, they can have hallucinations, and just a change in the patient is often just the presenting feature. Another major challenge affecting delirium detection, apart from the heterogeneous ways in which it can present, is the unfortunate fact that over decades, medicine and nursing and other healthcare professions have used a wide variety of different words for delirium. The term acute confusional state was the recommended term a few decades ago, and it has persisted in the literature and in clinical care. And its sort of cousin, acute and chronic confusion, is often still used. I see that in ED letters all the time. Altered mental status is a kind of fudge term used by often neurologists in the United States. In other settings, you hear terms like ICU psychosis or pump head, in coronary artery bypass graft patients, and so on. And on the right, we have these terms which are informal descriptions of things that are often delirium. But what I would really like to advocate very strongly is that we stop using all of these terms inconsistently and just use the word delirium when it's diagnosed. Don't use acute confusional state or acute and chronic confusion ever again. Just use the word delirium if you think that it's delirium. And that will really help in coding and also in communicating with families, in giving leaflets out, and overall increasing the rates of delirium detection. So in terms of how we implement better ED delirium detection, I think one clear lesson is that we do need to use a tool for this. And quite a few studies have looked at clinical gestalt, or just overall clinical impression of whether somebody has delirium or not in ED, but also in many other settings, especially in the intensive care unit. And the conclusion of these studies is generally that it doesn't work that well, and often that people are more confident about their abilities than shows up in the studies, and they often miss delirium without a tool. Another reason for using a tool is, of course, that the tool enables a standard approach, standard ability to communicate this in the notes, so you know what approach is being used, and perhaps you might even know what tests have been done within a tool, so you've got a benchmark for how that patient is at that point in time, as opposed to saying patient is delirious today, which is much less useful than a more detailed description. So there are more than 60 delirium tools in literature, but most of them are research tools, and not many at all are suitable for the ED, and in fact very few have been specifically validated in ED settings. Some processes involve 2 stages, so there's a very quick assessment, and if it's positive it moves on to a more detailed tool, and I will be discussing that in a second. But just to simplify things, going through literature and various systematic reviews, it seems that there are really only these 3 tools which have been assessed in relation to their psychometric performance and practicality that are useful in the ED. The original confusion assessment method, although it is quite well validated during research studies, in fact has little support for use in the ED because it's too long and it's not really worked over decades of attempted implementation. So I'm going to focus on these 3, especially the 4ET. So I'll just start with the Dilemma Triad screen. I'll be interested to hear any comments on this. So this was developed as a way of, specifically for ED use, as a way of trying to reduce the time burden involved in delirium assessment. And the idea is that you ask the patient, that you first assess level of consciousness with a brief clinical interview, discussion, and if the level of consciousness is abnormal, then it's that the tool is positive, and you proceed to a more definitive delirium assessment. If the level of consciousness is normal, or certainly normal enough to allow a discussion, then you ask the patient to spell the word lunch backwards, and if they make more than one error in that, then that's also considered a positive screen. And the sensitivity is pretty high for this tool in the study that it was done in, and it's a very quick test. And I know that it has been implemented in some American centres, although I'm not aware of the results in real clinical practice. This other tool, the bCAM, the bCAM, was designed also again specifically for use in the ED, and there are 2 or 3 studies of the bCAM. It does have good psychometric properties, and it's very short. It's around 2 minutes, as I say, specifically designed for ED use. It does involve a cognitive test, the months of the year backwards, although that's the only kind of standard cognitive test in the tool. The disorganized thinking questions, will a stone float in water, yes or no, and so on, are more specifically around delirium assessment. And it also incorporates this altered level of consciousness, although this would already be present if you scored it positive in the delirium triage screen. Some training is recommended for this, but I think the bCAM is actually a reasonably good tool, and it's just that it hasn't really penetrated much into UK settings, so we don't have that much experience of its use, but I know that it is being used in some American centres. And the 4ET, which will be the focus of the rest of the talk, was designed in Edinburgh basically just for use in our own hospital because we were struggling to detect delirium. And it was designed for inpatient use at the bedside and meant to be very quick and easy. Since it was first published on our website in 2011, it's become the best validated delirium tool in the world, with more than 5,000 patients assessed in 23 studies. And it has become a commonly used tool in clinical practice in the UK, Australia, and some other countries, and it's also beginning to be used in the United States. It wasn't specifically designed for use in the ED, but it does have around 3 or 4 studies which have supported its use in the ED. The psychometric properties are similar to the bCAM, and it takes a similar amount of time as the bCAM. It does include specifically, as there's an intention in the design, some cognitive testing, so the AMT4, which performs similar to the AMT10, and months of the year backwards. These are items 2 and 3, which I'll come to. And this means that you don't need to use the AMT separately. And the whole idea in this element of the design was to avoid the need for 2 different tools, a test for cognitive impairment and a test for delirium, because it's just too long to do that. And the 4ET is widely used, and we do have some evidence that it's used, for example, in the National Hip Fracture Database in England, Wales and Northern Ireland. It's used routinely in hip fracture care assessment in inpatients. And in Scotland, we use it at the front door in the Scottish Hip Fracture Audit and in multiple different centres. And it does seem to work reasonably well in terms of having the positive score rates are equivalent to what you'd expect. And another point about the 4ET is that even if the patient is too sleepy to speak, they can receive a score on the 4ET instead of being considered untestable. So there's no unable to assess outcomes. And we say that no special training is needed for the 4ET, but what we found over the years is that it's easy to say that, but in fact, anyone doing the 4ET and trying to come up with a score to tell if somebody has delirium really needs to know something about delirium. So I think that all healthcare practitioners do need good knowledge of what delirium is before they apply tools like this. So just to go through the scoring now. So the score range is 0 to 12, and a score of 4 or more is suggestive of delirium, 1 to 3 of cognitive impairment with no delirium, and 0, no significant cognitive impairment and no delirium. This is just a simple framework though, and of course, in every case, clinical judgment is needed to confirm. I actually reject the notion that any test can be diagnostic, even though some CAM papers, like the 3D CAM, is said to be diagnostic. I just don't think that's true. I think in every case, a clinician needs to make a judgment as to whether the score is correct in relation to what they think is really going on. So item 1's a simple arousal test, alertness test, where if somebody is clearly sleepy or agitated, especially after the first few seconds of interaction, then they score a 4. And as you'll recall, a score of 4 or more is indicative of likely delirium. So a bit like with the delirium triage screen, if somebody has altered arousal, then this is considered to indicate delirium. The second item is simply the AMT4, where you ask the age, date of birth, the place that the person is in, and the current year, and the scoring is there. And you'll see that if there's 2 or more mistakes or the patient is untestable, they get a score of 2, and I'll come to that in a minute. Item 3 is months of the year backwards, and you just ask the patient, please tell me the months of the year in backwards order starting at December. And in some occasions you need to do a prompt to get it going, and then the scoring is as is described there. Again, there's an untestable category, and this means somebody who just can't start the test at all because they're too sick, too drowsy, too inattentive, just can't understand what the test is asking them. And these two cognitive tests in the middle of the 4ET can sometimes yield a score of 4 on their own, which then leads to the possibility that the person has delirium. And this was designed because we knew from previous work that lots of delirium tools relied too much on cognitive testing, and then when the patient was too unwell to respond to interview or cognitive testing, that the tester would just abandon the test and say they were unable to do the test. This used to happen a lot with the EMT10, not a delirium test, but a cognitive test, but people would just say unable to do it, and no score was given, so the patient was left in a kind of diagnostic limbo. So to avoid this, the 4ET had the design feature of when somebody is untestable on the cognitive tests, then they get a score. So the bottom line is untestable patients are not unassessable, and they get a score in the 4ET. And the final item is perhaps the most difficult one sometimes in the ED. And this is to determine if there's a change from baseline. Is there an acute change in the patient's cognition, or is there fluctuation? And the 4ET is written that it asks if there has been significant change or fluctuation in these mental features, which has arisen over the last 2 weeks and it's still evident in the last 24 hours. And basically this is something that requires informant history most of the time. So the informant could be written, could give the information in written form if it's a GP letter. If it's an inpatient, could be the case notes. You can make a judgment if you think that the patient is clearly not the same as what they would be like at home. For example, if a patient who is living independently and normally gets out to the shops and they come in very sleepy and unable to talk, obviously that's different, and I think it's reasonable then to make a judgment that they get a score of 4 because there's obviously an acute change. Sometimes the patient knows if you ask them about the typical features of delirium, which might elicit paranoia, such as are you concerned about anything going on here, or if they have hallucinations. So it does take more time than the bedside assessment sometimes because you have to go and seek the information from other sources. And in my experience, this is the item that causes the most trouble. Some studies show that only 2/3 of patients have an informant available readily, either with the patient or with a quick phone call. So sometimes if there's no evidence of any change and you don't have an informant, you have to score this 0 unless you're sure. But what's important is not to just leave it unscored. So if there's positive evidence of change from any of these sources, score it 4. So these items all come together to create the final 4ET score, as I mentioned before. And one thing I think that probably is helpful in the ED is that you can get a score of 4 or more from the alertness and the cognitive testing alone without relying on there being an informant to confirm the acute change. So you can make a provisional diagnosis based on this. And I know that from some EDs that have implemented the 4ET, they find this very useful because many other delirium tests rely on there being evidence of acute change. And if there's no one to supply the evidence, the tool just doesn't proceed. It just gets abandoned and isn't completed. So I hope this has been a useful overview of the process of 4ET scoring. The website above has quite a lot of resources, including case examples and a guide to delirium care as well, which I hope might be useful. So just to conclude, I think there's really no doubt that we need to screen for delirium in the ED. The RCM recommends doing this in all over 75s and others at high risk. We really know from quite a lot of research that to properly detect delirium consistently, you need to use a tool, and there probably are 2 main candidates to consider, the 4ET and the bCAM. I know in the UK we're recommending the 4ET, but by all means, have a look at the bCAM, and at the two-stage process. It might be that in the ED this turns out to be a useful thing to add, perhaps adding the delirium triage screen or some other brief assessment before proceeding to a longer tool. We now have the major task of implementation and checking that we're doing a good job of this, which isn't the scope of outside of the scope of what I'm talking about today, but it's certainly something to be acknowledged, and to really shift into a position where it's normal in the ED to consider delirium as a medical emergency that needs to be detected and treated properly, instead of in the position it's been in historically, which is just not to be mentioned or to be dealt with in a very variable and incomplete way. Thanks very much for your attention.